Thank you, Maulin bhai. Thank you, Meet, and I appreciate this. So, am I audible? I'm going to talk about supracondylar humerus basics of pinning. So, few things which all of us know, just a sort of recap, the commonest fracture, and because of this evolution of close reduction and pinning, the rates of malunion and compartment syndrome are going down. As you know, it's common between age group 5 to 7, more common on left side. Evaluation is very important. One should look for soft tissue swelling, ecchymosis, skin puckering. Neurological examination and vascular examination is very important. I'm not, because of lack of time, I'm not going into pink pulseless hand or pulseless white hand, but one should evaluate the vascular status. Quick neurological assessment. The first one is showing the function of the median nerve, that's radial nerve, that's ulnar nerve, and that's anterior interosseous nerve. So that's the quick neurological examination when you are examining the child. So radiographs, AP and lateral view should be assessed on true lateral radiograph. The anterior humeral line should cross the capitulum through the middle third. But if it is an extension type, then the capitulum is posterior to this line. But beware, in young children, the capitulum may be posterior, especially children less than 3 years of age. One should look at the Bauman's angle. If in doubt, compare with the opposite side. So lateral radiograph, the other pointers are the position of the teardrop, the diaphyseal condylar angle. This angle, the condyles are flexed about 40 degrees to the diaphysis, the anterior humeral line, the coronoid line, and the fat pads. As you know, fat pads are the clue towards diagnosing the type 1 fractures. And all of us use this Gartland classification or its modification, which includes type 4 or the unstable type. Watch for medial compression. If it is present, it can lead to cubitus varus, and we must recognize and reduce and treat it as shown in this. So treatment, initial management is splint with whatever position the elbow is. We try not to flex further, and then definitive treatment. So I'll be talking more about the close reduction and pinning and some of the tips and tricks. There are various methods, but we will be focusing on what I use in my practice. So when to operate? In general, if the vascularity is abnormal, if it is associated with nerve deficit, then yes, it should be treated on emergent basis. But if the vascularity is okay and if the nerve function is okay, then it can be done on sort of next day morning at the earliest possible, rather than waiting for a day or two. So this paper, they talk about, they gave us this protocol. They believe that if the fracture displacement is more than 25 millimeters, then probably one should consider treating it early. So in general, in my practice, if I can do surgery before 10 o'clock the same night, I do it. If not, I try to do it the first case as next day morning. Rarely, if it's a dysvascular limb, it's if there are any concerns about vascularity like a pulseless right hand, then only I operate at night with the help of backup of vascular surgery. So way I do it is supine on a hand table. I usually use Shyam from the foot end. I prep and drape whole extremity, and I do not rotate the Shyam, but yes, sometimes if it's a very unstable fracture, then that is what is needed. The reduction is achieved by traction in 30 degrees. One should not put their hands anteriorly because you can compress on the vessel. Then correct varus valgus and then hyperflexion. So what is the position? So I use this rule of thumb. Thumb should point towards the direction of displacement. So if it is a posterolateral displacement, which is little uncommon over here, then you should supinate the forearm. But the common is the posteromedial, then it should be pronated. So try it. I find it very useful because in initial days of practice, it's always confusing whether to pronate or supinate, but that's what I follow, the rule of thumb. So reduction is achieved. Flexion over the olecranon process, then the finger should touch the shoulders. That tells us that we have achieved sufficient reduction and the fracture, the continuity of sagittal alignment is achieved. Check for radial pulse. I take oblique views. I look for medial and lateral columns. I look at the anterior humeral line. Here you can see that this needs more reduction. It is still in extension, but this is reasonably good reduction. So if it is not touching, I would maneuver it further. So this is the checklist I usually go. I look at the anterior humeral line, which should pass through the center. But as we were discussing, in kids less than 4, it may be variable. And restoration of rotation, I look at the figure of 8. I look at the combination of medial and lateral columns. Some lateral translation is acceptable, and I also look at the radial pulse. And fixed with K wires, I usually prefer lateral entry pins. My routine protocol is to use 2, rarely 3 wires from the lateral side. Put those wires while maintaining the elbow in hyperflexion. Start with the lateral pin, and we'll talk about when to add medial pin. What are the indications? So cross pinning studies have shown that there is no appreciable clinical difference, even though biomechanically cross pinning is more stable. Ideal configuration is pin engaging medial and lateral columns. They are divergent or parallel, and it is acceptable to cross the olecranon foci. It will give us 4 cortices and more stability. As you can see in this picture, they are all divergent pins. That is how, if I'm using 2 pins, that is how I do it. I look at this line and look at this. So I do this stress test after K-wire placement. I apply gentle varus and valgus stress and check it under fluoro or continuous fluoroscopy. And I watch for opening of the fracture site. I do the same thing in the lateral view, gentle flexion and extension. And if the fracture is opening up, I would consider revising that fixation or adding another pin. So that is what I always do under CM. So when to use 3 lateral wires? Some of the fractures which are very unstable, I use those 3 pins. So when to use medial pin? Some surgeons always prefer doing cross pinning, but I reserve medial pin if there is medial combination, if the fracture is oblique, if it's unstable fracture, type 4 fracture. One must remember that the risk of ulnar nerve injury is about 6% in the medially placed pins, and there are ways and means to avoid this ulnar nerve injury. So let's look at this picture. So you can see the clear S deformity. There is ecchymosis. The shaft has gone through the brachialis, so milking maneuver is needed to bring out this. And then once reduced, it was very unstable. So I used, in addition to 3 lateral pins, I used 1 medial pin. So in order to minimize that ulnar nerve injury, one should keep elbow in extension, start anteriorly on the medial epicondyle, and if in doubt, if the elbow is swollen, one may need to make mini open incision and use drill guide to protect the soft tissues. So convergent wires, they should be avoided. Wires not having hold in the medial column, as you can see in this picture, they should be avoided because this is very weak construct and the chances are. So post-operatively, I put them in a cast about 70 degrees of flexion. Hyperflexion is avoided, and I remove K-wires at about 3 to 4 weeks. So some of the troublemakers, how to identify them. So this is for straightforward supracondylar humerus, but fractures with obliquity, high supracondylar humerus fractures, flexion type fractures, fractures with combination, and supracondylar turning into TY fracture. So we can, if we look at the radiographs or intraoperatively we assess them, most of the times we can identify the troublemakers, and we can modify our plan according to those fracture types. I know Vidyasagar is going to speak more about it, but just going to give you a free, quick overview. So let's look at this 9-year-old with this fracture. So one must identify that this is not typical supracondylar. This is a flexion type. It is slightly higher up. It's going above the olecranon fossa, and there is some combination. So these fractures, they have high probability of ulnar nerve injury and may need open reduction. And if we try our routine maneuvers of hyperflexion, then that is what we achieve. So definitely this is a big no-no, and we need to modify our techniques. So something else was done. A transolecranon wire was used to temporarily stabilize this, and then this was fixed with 3 lateral and 1 medial wire, and she went to have good union and good function. Another case, a 19-month-old girl. So supracondylars in young children, like infants and toddlers, they are very different than what we see typical 7-year-olds. So she fell from first floor. She also had bilateral rib fracture, head injury, and that's the fracture. So again, this is not typical supracondylar. We can classify it as, I don't know, flexion, or it's a very very atypical sort of picture. So I tried intrafocal reduction with this wire. So I could achieve it. I could get it back, but then it was in lot of rotation. So here you can see that this is in excessive rotation, which is definitely not acceptable. And this obliquity that was making things difficult. So after this intrafocal reduction, I put a wire in the distal fragment and rotated it out. And once rotated out, I put 3 wires from the lateral side, and I could hold it, and then I put above elbow slab, and it went on to heal well. So sometimes you need to modify your technique or use combination of 2 or 3 techniques to get this reduction. Another picture. So not a great looking X-ray, and we are not sure what exactly is going on. Looks like supracondylar humerus, but that's all you got. So intraoperative radiographs, again, not very clear, but if you take oblique views, it shows that it's a TY fracture. There is a intra-articular component and this big chunk of medial condyle, and there is another lateral piece. So this was treated. We could achieve close reduction, and here one must put a medial pin. So it was put and it went on to heal. So be aware when you're treating fractures with obliquity, high supracondylar fractures, flexion types, fractures with combination, and fractures which may turn into T or Y fractures. Another example, another 1.5-year-old. So here I tried close reduction, but it's just not possible. Again, what to classify this, I don't know, but I did an open reduction and fixed it with K wires. So sometimes it's best to consider open reduction rather than giving multiple attempts in scenarios like this. So in summary, identify and evaluate every supracondylar can be difficult. Anticipate difficulty in achieving close reduction, modify your technique accordingly, be prepared to do an open reduction, and if you are seeing atypical fracture or intraoperative problems, counsel parents accordingly. Thank you.
Thank you, sir, for that wonderful talk. If there are any questions, I would request everyone to ask them on the chat. So I had 2 questions, sir.
Yes.
What would be the number of attempts at reduction that you would advise before you do a mini open thing?
So usually I would consider giving attempts for about 15 minutes. I don't have fixed number in my mind, like forearm fractures or so. But I would look that with every reduction attempt, am I making any progress? So I think I have slightly higher threshold for supracondylars attempting close reduction rather than going. Opening, yes. If there are vascular issues, I have very low threshold. But if there is no vascular issue or neurological issue, then I would try my best to get close reduction.
No. Sir, when would you use an arthrogram, sir? Do we need to use an arthrogram?
So yes, that's very good question. So young child, 1 or 2 year old, where we are not sure what we are treating, if we are suspecting intra-articular fracture, then I would use arthrogram, but not otherwise.
So our next talk is on the tricky situations in supracondylar fractures by Vidyasagar, sir. So, sir, if you would like to share your screen.
Yeah, hello, good morning, everyone. Thank you, Meet, and
Thank you, sir.
very nice and brief summary by Dr. Ashish. I think Dr. Moulin was supposed to speak on atypical fractures, but I'm going to speak on a little other than atypical, little complicated thing. I'll share my screen now. Is the screen visible?
Yes, sir, it's clear, sir.
Yeah. So I'll be discussing 2 cases, quick and short, and we have a lot of learning points there. So this is a 7-year-old boy who presented with a road traffic accident, and he came in the ER at around 8 p.m. in the evening. We can see there is a swelling in the arm, elbow, as well as the distal radius with a deformity, and anterior slight open wound there, just near the cubital fossa. So on physical examination, there was swelling, what we described. There was no distal pulse, but hand was pink. It was not pale. And then we could make some irregular waveform on pulse oximeter when kept to the same hand. And SpO2 was about 92. So now we are dealing with a situation where there are in the upper limb 3 fractures overall, a segmental humerus fracture and a distal both bones forearm fracture as well. And upon that, there is a compromised pulse. The neuro evaluation could not be done because of the pain the child was having. And then in this situation, where there is also an open wound, it is very difficult to control the reduction like the way we do with the routine supracondylar. You need a good lever proximally, and the forearm acts as a lever distally, and on that reduction happens. But here we know there is a humerus shaft fracture. How are we going to get the reduction? That's one thing. And of course, vascularity, what we are going to do about that. So questions what come to our mind is, let's say there is no vascular surgeon. What are we going to treat this conservatively? First question, because there is a segmental fracture, almost like a floating elbow, it's a highly unstable and high risk for compartment syndrome. So the option of conservative treatment doesn't arise, or it's not the best option. And if you want to operate, do you want to operate immediately? Yes, because there is no pulse, the hand is pink, yet there is a dubious waveform. I would like to operate this first. And then comes the question, which fracture are you going to fix the first? And then what will you do about the vascularity once you do the reduction? So what we did was I plated the humerus first so that we get a nice lever arm superiorly, and then we can have a reduction as a routine distally. So after that fixation, I tried the close reduction and it was excellent in both the view, the Jones shoot through view and lateral. And distal radius was managed with just a K-wire after manipulation. The supracondylar fracture was managed with 2 lateral and 1 medial side pinning. And that's the end reduction. So after this, the hand remained still no pulse, and there was an open wound there. So I took an advantage because I was right there. I had already informed the vascular surgeon that we might need you, be prepared to come. So when explored, I found that there was a laceration there in the artery, as well as thrombus formation. So I did the routine thing, warm saline, pack, some lignocaine, nothing happened, and pulse remained still no pulse with a similar waveform. So then we called, that's the point when I went away and I handed it over to the vascular surgeon, and they did a bypass grafting. You can see the graft there. And after that, the good pulsations returned immediately. And that's the child. And we can see the waveform is not bounding, but yes, it's good. And then FSPO2 is about 100 pulses returned. That's the wound status. While healing, child was put on anticoagulants for, I think, 2 weeks or so. And at the end, we found this. All the fractures healed. There was a slight movement at the supracondylar fracture. So I believe it is important that I think we should be there in the theater till the vascular surgeon finishes the job, because they do manipulation and things may move around once you finish and go. So because we had excellent reduction intra-op, and now we see there is a slight change from that status. So definitely things have moved. And that's why this case is challenging, because there is a segmental humerus, and that's the end healing. Child had excellent function, good range of motion, no deformity either in the elbow or in the wrist area. So, Dr. Ashish, anything you would like to point out here in the case? Hello.
So, Vidya, very
Yes, sir.
nicely done case. What was the time when you opened and the vascular surgeon came in?
Yeah, so it was right in the middle of the night. It was around 12 or 1 or so.
See, I had one experience similar where the vessels were in spasm, and vascular surgeon said, let's wait for some time, because sometimes the vessel in spasm and you wait, and in that particular case, he said, we'll see in a couple of hours, and then pulse resumed. So that's what I try to say, that the vascular surgeon, they give all the opportunity for the natural canalization if it can happen. But in your case, we could very easily see that the vessels were thrombused. And the other thing is, could you do the TENS in humerus? That's again an option of antegrade TENS, if not the plating, you know.
Yes, that TENS was an option, but I think
from stability point of view, you plated
correct,
it.
because it's not so rigid, and while my manipulation maybe will start bending or so, then that was the concern. And this looked like a fairly straightforward procedure.
Yeah.
Rather than attempting getting 2 wires in S and C shape and aligning them in the distal humerus, which becomes a little bit more difficult for me as such.
Yeah.
And regarding the vascular surgeons, sir, you brought out a good point, but most vascular surgeons, in my experience, at least, they want to explore. They never want to wait and watch. Once they find something, they usually operate. And it's mostly our
the reason behind this also, we also had one child with white limb, and even after reduction, there was no pulse. So the patient was taken by vascular surgeon, and I think they did repair, and collaterals developed. But after the next day morning, again the pulse went off, and the vessel got re-thrombused. But the collaterals were so strong, the limb turned warm. So then we continued. We did a repeat Doppler, which showed that there is, it had got re-thrombused to some extent. But collaterals developed so quickly, and then we continued with that treatment. So that is a study by Sanjeev Sabharwal and colleagues, that about 70% vascular repairs, they got reoccluded. But this is what is important is the development of collateral circulation, which will keep the limb alive. So wonderful case. Yeah. Comment from anyone else?
Anyone else wants to make a comment or a question? Just 2 things, Dr. Ashish, regarding your case, which was pale white. Pale white is a classic indication. Even after reduction, if you don't get it, you should hand it over to the vascular surgeon. And restenosis rates are high. Probably that's why in my case, they choose a bypass graft rather than repairing or meddling with the injured intima.
So the question is, does the rule of thumb is same for flexion type?
Flexion with vascular these things are?
Oh, no. The rule of thumb, like the applying plaster in pronation or supination. So the rule of thumb, or what I follow is, if the fracture is open laterally, what I mean is, if the fracture is open laterally, then you pronate, because that pronation will push the lateral condyle proximally. If it is open medially, then you put it in supination. And if it is not open medially or lateral, then you put it in supination. So I pronate when there is lateral opening at the fracture site. And I don't remember recently I have done that. So most of the time in supination, that reduces. Once you do your maneuver, look at the IITV. If the fracture remains bit open on lateral side, then only pronate, or the supination is okay. So don't confuse yourself, about with rule of, I mean, it's a good rule, but that even after the fracture displacement, when you do your maneuver, the fracture may get reduced completely. Then there is no need to do hypersupination or pronation.
Correct.
Yeah, Vidya, we can go ahead with the second case if you.
Yes, sir. Thank you. I'll continue with the second case. So this is a 6-year-old girl, which I had posted in our Pedipod group also. So this girl had a fall on outstretched hand, and she had initially consulted her local doctor, orthopedic surgeon, and he had advised surgical fixation after reduction. But all the times parents might not agree. They think things will settle down with time, and that's why they chose to manage it through a wait and watch approach. But after a week of that is after 6 days, is the screen interfering with the? So this is after a week, that's after 6 days, they came for opinion because some known doctor, common doctor had referred them. It can't be treated like that. You go and meet him. And then when the child came, yes, the distal pulses were good, but we can see the child has a AIN palsy here.
Yes.
Yeah, you can see a pointing index. And all the other fingers are flexing good, but the index and thumb not so much. So then I was in a dilemma. It's been a week, whether to go for manipulation, which can increase the risk of stiffness, or to accept this and correct something at a later date. But then even our group and everybody discussed, I think a week is okay, because the callus can be manipulated and changed at that point probably. So the questions which came to my mind was, will we intervene if the child comes late, and late, how late is really late? And then whether to reduce the fracture, if required, then open or closed, and you're going to do a medial or lateral approach, and what to do with the AIN palsy. So this is the intra-op picture when I decided that we'll try a closed reduction attempt. And this is slight overlap between the proximal and distal humerus, not yet reduced. And then with gentle traction over 10 to 15 minutes, I was able to get a bit of osteoclasis there. And however, then there was a medial opening here, we can see, and slight overlap on the, lateral opening and slight overlap on the medial side. And that's when I did a valgus force. You can see the radius and ulna moving on the lateral side. And then we got the medial reduction as well as closing of the lateral side. Then at this point, there was the shoot through lateral view where we could see that it's not in full reduction. So we pushed the olecranon and then flexed the elbow and pronated it here, because it's a posterior medial displacement. And we can see it's a fair reduction for this. And back we can see there is a callus which is there, which would prevent in a way our anterior translation here. So this is the shoot through, looked reasonable. And with that, I put 3 lateral pins I have put lateral pins, the first 2 pins, and then this is the additional pin, which I have put the small thin one, which is probably 1.5, 1.6 pin. And all the pins, even though radiographically they are there, I confirm generally through my feel whether they have the opposite cortex purchase or not. And it was stable. How do I check stability? Is just put the elbow in range of motion and see what's happening. And in range of motion, if after 5 rounds of range of motion, it remains okay in the AP and lateral, that means it's not going to move. And then I put a slab. And that's the end reduction. So what happened is post fixation, I looked pretty happy. Okay, we have got a decent reduction for 6 days old. Then when I checked the pulse, I didn't get a pulse at that point, which was bounding before. And ulnar pulse was there. There was no radial pulse. So then I waited for some time. And then after 15 minutes, we started to feel that radial pulse was feeble. It was there coming back. And this was the waveform, small waveform. And then the saturation was almost 98 there. So then I waited for another 10 minutes and extended the elbow slightly to about, let's say, 60 or 70 degrees. And then after 25 minutes of the fixation, we found that radial pulse was well felt. And then sometimes we wear the gloves and it may not give a sense. So I asked the anesthetist also to double check. And once this was there, that's the time we applied a slab in the same position. And then we came out. AI nerve palsy can wait because they usually recover without permanent sequelae. And post-op protocol is 3 weeks of immobilization from the day of surgery. And I started on indomethacin prophylactically to reduce the myositis rate. Thank you. Any comments or questions? I'm happy to.
Thank you, sir, for that. Yes.
Yeah, Vidya, nice case.
Thank you, sir.
Yeah, till 1 week we can definitely 1 week to 10 days at times. And after 2 weeks, I usually let it heal in an mal reduced position and then correct it. But till that time, you can always try reduction. Sometimes you might use an percutaneous osteoclysis. Ulrich pointed out, and how could you manage the most medial K wire, which is going medial to the capitulum?
Yeah, so that's correct. So the way I did it is the same flexion, because Dr. Ashish spoke about it. The hand should come and touch the shoulder. So in that extreme almost flexion, we get good space there. The one thing which I noticed is once I started extending the elbow, the ulna started interfering with the that medial K wire. But I don't believe it was in trochlear. I believe it was at the junction. And that's the thing which happens. But in extreme flexion, I think we can put the pin. But if we want to extend, it becomes a little difficult. That's why I've used a thinner pin also, so that I don't injure the medial ulnar nerve or any structure there with this penetration.
Yeah. The usual practice is for all the fellows, when you are doing lateral pinning, on X-ray, you look at the capitulum, divide it into medial and lateral half. Your first wire should be going from the medial half of capitulum, and that will be the 4 cortices pin. And your lateral pin should be immediately lateral to the ossified capitulum, and that will fix your lateral pillar. And those 2 wires should be diverging to have a good wide space at the fracture site. And many times 2 wires are okay, and if it is still a bit unstable on internal rotation, then you can add the third, either medial or lateral pin, and check the stability. Yeah, so both the cases are very well managed with Vidyasagar. Nice cases. Yeah, any comment or question?
There are some questions in the chat box. I'm not able to open, and I'm not able to stop the screen sharing also.
Let me see.
Sir, I think they have been answered. One question by Dr. Mithun is, If ulnar nerve is
If
injured in
ulnar
unstable
nerve is
fracture,
injured, when to remove the K wire? Vidya, can you take that question?
So sorry, I didn't get the question.
When the ulnar nerve is injured, when you should take the wire off?
Yeah, so usually if I see an injury post-operatively, I don't immediately take off the ulnar pin. If it is even there, I wait for some time and then probably around 2 to 2.5 weeks, 2 to 3 weeks, I remove it. I don't remove it immediately if I am not sure that the stability will be there after removal. But otherwise, if I'm not worried, it's just an extra pin, I remove it immediately post-operatively. Yes.
Yeah, so if you have noticed that there is no ulnar nerve palsy pre-operatively, and immediately after you finished your procedure of cross K wiring, you found that the ulnar clawing is there. See, most of the times it is the winding of the ulnar nerve sheath around the soft tissue. So my practice is not to remove the wire, but to explore that area and make sure that you are not going through the ulnar nerve. If you are clinically well aware that you have, while putting the ulnar nerve, you have to make a small stab incision, keep elbow extended, put a drill sleeve or a wire bender sleeve to put your wire, then you can avoid, and you have to be a bit anterior for the medial pin. If still you have doubt, then you can explore, you make sure the ulnar nerve is still lying behind, and then you do the release of the sheath between the wire and the ulnar nerve. So you are sure that this is just a neuropraxia which is going to recover, and you are not passing through the ulnar. Sometimes what happens is post-operatively also we see that everything is okay, and at 3 weeks time patient comes with clawing, and there is a paper which suggests that about 90 to 95% ulnar clawing resolves by 6 months. And by 6 months, you still have problem of hypothenar atrophy, clawing, and hypoesthesia. Then you might explore and you might like to do the resection of that neuroma and putting cable nerve grafting. But that instance is very low. But I differ with Vidya that if I find it immediately post-operatively, then I might take the child back in and make sure that ulnar nerve is not violated.
Yes, sir. Yeah, I think the prevention of injury is more important.
Yeah, that's right.
So the keys would be elbow extension while pinning, and then pin slightly anterior on the medial side. And then I use the thumb to push the ulnar nerve while doing that.
Yeah.
The other hand. And then I put it on not the proper drill mode, it's on a ream mode. So that low rotation is there and it goes on slowly.
Yes, the next question is how many attempts of reduction should be performed?
that's
That's answered by Dr. Ashish.
Oh, okay.
So we have one question by Dr. Puneet. Can median or ulnar nerve get trapped in the fracture site? If so, how do we decide preoperatively whether we have to dissect the nerve or not?
Yeah, so that's again a very valid question. So the whole thing is, if we are getting a fracture gap after reduction and there is a vascular compromise, of course, nerve we can't check intraoperatively, but pulse is an indirect indication. Both the vessel and this thing lie together. So if there is a fracture gap intraoperatively, then that's an indication to explore what's happening. And it can be done through a mini this thing. Just make a slight lateral incision, slide your finger below the periosteum and go all the way to the fracture, and you can see what's happening by a manual palpation. And that's the way I do it. If there is no fracture gap, then I would just wait and watch probably.
Yeah, I agree with Vidya. And mainly the flexion variety fractures, and low supracondylar, they can have ulnar nerve entrapment. And rest of this, we can have median or anterior interosseous entrapment. So the reduction should be 100%. in both the planes. That is the key to make sure that nerves are not interposing. Indication of arthrogram, did Ashish discuss that?
Yes, that's
Yes, sir.
finished. Yes.
Okay. Yeah, so again, we do it in very young children, low supracondylar, physeal separations. So those are the indications of arthrogram. Right. So if any other questions, I will leave. I have to visit an hospital. Thanks, Vidya, for your time. And Meet, you can conclude.
Yes, sir.
Thank you. Thank you, Maulin sir.
Yeah. Take care.
Thank you, Vidya sir and Ashish sir, for your time. It was a very interesting session, sir.
Thank you, Meet. Do you have anything to present?
No, sir. I think we had only these two cases. I mean, these two.
Okay, then I think we are at the end of session, right?
Yes, sir. We have finished early today.
Thank you so much. Yeah.
Thank you, sir.